essentially to talk about the non-invasive diagnosis of amyloid, not so much as the modalities that are required to diagnose it, but the clinical situations in which you want to suspect this diagnosis. The reason being, there is no medication to actually leach out amyloid protein once it's deposited in tissue. But you have enough medications to ensure that it doesn't deposit in tissue. So what is required is essentially a high index of suspicion, and we shall go through a few case studies in order to illustrate the same. So at the outset, echo imaging criteria for all of us who do a lot of echoes is mainly looking at an ejection fraction plus or minus equal to 50%, a regional wall thickness of 0.42, an absolute mean GLS of less than 15 with a relative apical strain sparing. The red flags on echo are very, very minute things, stuff like pleural pericardial effusions, you have changes in the global longitudinal strain, small A wave on inflow Doppler, which is very highly significant for predicting a stroke in patients with amyloid, poor pump function, poor reservoir function. Going on from there, there are other various imaging targets also which can be used. Mainly, it is the discordance between the ECG and the echo that has to be noted as the most important clue that there is something wrong. In a patient without any history of hypertension, you have a thickened wall, but the ECG is not showing the relative hypertrophy that should be seen in the precordial leads. Again, we are worried about it. On MRI, one of the key features remains an expanded extracellular volume, mainly because these patients have extracellular deposits of amyloid, which in turn leaches the fluid in there. On CMR, you have high T1 signals, increase in the ECV, and a variable non-contiguous late gadolinium enhancement, which in turn then leads you to go for this relatively cheap study as the technetium pyrophosphate scan, where you have ratios between the uptake of pyrophosphate within the heart as compared to the local bone. The limitations of it exist, especially if you're not doing it well enough, if there is non-understanding of the blood pool uptake, and you have to minus that from the scans in order to give yourself a good value. So with these ideas in mind, let's go to our first case, where we have one of our typical patients, namely a elderly patient, 65 years of age, presenting with recurrent evidence of episodes of loss of consciousness, ECG suggestive of a high-grade AV block or CHB, echo suggestive of LVH, there is no history of hypertension, septal thickness is 1.5 centimeters with a normal ejection fraction, and importantly, raised cardiac troponins. High troponemia is again a very important factor to consider the possibility that there is underlying amyloid. So the ECG is as usual, as you can see. You have the signs of complete AV block there. There is relative discordance which is noted. The clinical suspicion of cardiac amyloid in this situation is driven by mainly the presence of an increased wall thickness, the red flag symptoms in a male greater than 65 years of age. So in our patient, we did have a 65-year-old male. We have a patient who has got left ventricular hypertrophy. We have a patient who has AV block and a Sokolov-Lyon index of less than 1.9. Again, deemed as a very high possibility for having cardiac amyloid, and the technetium pyrophosphate scan in this case did show the presence of uptake, suggesting this was cardiac amyloid, and the patient was started on tafamidis. Going on from there, let's go to the second case. This is a slightly unique case, may not be routinely found, but yes, seen if there is enough volume of patients with atrial fibrillation. 35-year-old woman without any other significant comorbidity, presenting with atrial fibrillation, recurrent episodes of atrial fibrillation, normal ejection fraction, resistant to 2 antiarrhythmic drugs, normal coronaries, ejection fraction being normal, no atrial enlargement, was taken up for an ablation for pulmonary vein isolation. This is what you can see on the left atrial map. You can see the 4 pulmonary veins there, and the initial view is mainly a PA. This is the posterior wall. This is the anterior wall. Whatever you can see in red is essentially a low voltage area. For a 35-year-old woman without having any valvular heart disease or any other predisposition, why should there be such a high atrial myopathy? That led to our suspicion that this could be something more than just atrial fibrillation, which is non-valvular. We worked her up for amyloid, did find a positive pyrophosphate scan without the overproduction of light chains. Again, that is critical because an AL can be seen with a pyrophosphate scan in about 2% of patients. So you need to prevent or decrease or rule out with immunofixation overproduction of light chains. Remember, she's not a 64-year-old patient, she's a 35-year-old one. MGUS can always be present in these patients. So again, worked up for amyloid, did not get any obvious light chain overproduction, sent a gene, turned out to be genetic abnormality for the presence of ATTR-CM. So again, high index of suspicion driven by mainly an abnormal finding in a patient who should not have had that finding. Going on to this, case number 3, we do have a 54-year-old male presenting with one of our most common clinical issues, syncope. A TMT was done, patient ended up having syncope on the TMT. At that point in time, the consultant cardiologist implanted a pacemaker because there was essentially only 79% of the maximal age-predicted heart rate, and they gave the patient a CLS device. But despite this, the patient continued to have shortness of breath, progressive dyspnea, deterioration to NYHA class 3. Because of the presence of a pacemaker, an MRI was not preferred because of the lead artifact. GLAS was done in sequential about 3 to 6 months apart, and you did see the change in the GLAS there. There is worsening of the GLAS score here with relative apical sparing, suggested that there was some amount of amyloid going on there. The autonomic function test did reveal significantly reduced power, showing predominant sympathetic overactivity with definite involvement of the cardiac function tests. And as you can see, tests for overproduction of light chains did show a high kappa lambda ratio, suggestive that there is overproduction of light chains. A bone marrow transplantation did improve his clinical condition, but the shortness of breath remained because the AL amyloid was already deposited. Again, a common symptom presenting in an uncommon age group, evaluated beyond the routine evaluations, did lead out to a diagnosis of amyloid. This is one of the more tragic cases that we had, which was elderly lady, known case of diabetes, presented with paresthesias. EMG showed low motor neuron neuropathy. Neurologist conserved it. Patient developed weight loss. Diabetes was associated with low immunity, developed cervical lymphadenopathy, did do a biopsy from that location, was diagnosed to have granulomatous lymphadenopathy as a result of us started on AKT. Then she developed foot drop. At the time of foot drop, there was a worry that there was something else going on, but not evaluated further. Presented to the cardiac emergency with one episode of heart failure with this ECG, NYHA class 3, LVH on echo, and classically you can see the discordance that there is no significant LVH on the ECG. Troponins were elevated, as was BMP, but patient had a normal coronary angiogram. She did have an exudative pleural effusion. 2 months after this episode, she came back to the hospital with an episode of dysphagia. At that point in time, when a PEG tube was put in, a biopsy from the fat pad was taken, which was suggestive of amyloid. But it also suggested that she had a lower motor neuron disease, which was then frequently progressive. Evaluation of the bone marrow there suggested 30% plasma cells with increased lambda light chains, suggestive of smoldering multiple myeloma, for which there was no treatment. Because of this factor, she also responded to torsemide better than furosemide. But at the end, because of the rapid progression of the disease, we weren't able to, she did not survive. This again suggestive of the fact that a simple peripheral neuropathy in a patient with diabetes with certain other risk factors needs to be considered for an abnormal presentation for amyloid, rather than just saying, oh, it's diabetic neuropathy. This can actually be progressive, and the discordance between the ECG and the echo seems to be the key criteria at this point in time. A 24-hour blood pressure would have definitely ruled out the possibility that the patient did not have hypertension, which would have perhaps pointed us out in the right direction. The other question here is, since the patient had multiple myeloma, is it important that we consider AL amyloid at all times, or should we consider ATTR amyloid also? In fact, the commoner amyloid in patients with multiple myeloma remains ATTR amyloid and not AL amyloid. The reason why it is being so important is perhaps there is some treatment available for ATTR amyloid today than was there about 5 years ago. So if kind of a flow chart for these patients, if there is a high index of suspicion for cardiac amyloidosis, you do want to do the scintigraphy with the SPECT scan and do the hematologic test to ensure that you use serum and urine immunofixation test to rule out overproduction of light chains. If the pyrophosphate scan is positive, then it's very high chance that it's cardiac amyloidosis, ATTR type, especially if there is no light chain overproduction. In the presence of light chain overproduction, you may then want to do a biopsy and send it for immunohistochemistry to figure out the difference, whether it's actually ATTR or AL, because the treatment between both of them is entirely different. The prognostication of ATTR wild-type amyloid remains very critical, where if you remember in our last patient, she did have elevated BNP and had elevated troponins. This is suggestive of injury to the myocardium, and if left untreated, can lead to rapidly worsening heart failure and death. Going on from there, my last case for today is a patient who is essentially a 75-year-old male, dyspnea on exertion, angina, 2 episodes of syncope, and an echo suggestive of severe aortic stenosis with a velocity maximum of 4.5 meters per second. Thickened aortic valves, normal ejection fraction. Should we even consider amyloid in this case? This is the Indian publication for the same from the All India Institute, which did show a significant proportion of these patients actually having myocardial and valvular amyloid in these patients, and aortic valve replacement did provide benefit to these patients over and above just treatment for amyloid or treatment of the heart failure. So again, an additive factor in an already coexisting condition which may give better benefits, especially in the era of TAVR, where TAVR is being widely accepted in today's day-to-day age, and improvement of the patient may actually be manifold provided the diagnosis of ATTR amyloid is already made. The RACE criteria is a useful criteria for us to have the suspicion of amyloid, which mainly considers of the parameter of bilateral carpal tunnel syndrome, a right bundle branch block on the ECG, an elevated age, a persistently high troponemia, an interventricular septum of greater than 18 millimeters, and a discordance between the ECG and the echo where the Sokolov-Lyon index is less than 1.9. Again, a TAVI patient presenting with a lower ejection fraction, now nearly 40% of these patients seem to have amyloid, which is responsible for the heart failure in these patients. Finally, at the end of my presentation, I would like to kind of bring your attention to what is a pet child of mine, is the ability to have AI assisting our ECG diagnosis for amyloid, where you have got algorithms based on neural networks which can tell you far more in advance that this patient has amyloid. In this paper, with this algorithm by Dr. Grogan, you were actually able to predict the presence of AL amyloid around 3 years before the actual presentation clinically. So use of factors which are going to help us increase our suspicion for amyloid seems to be the key for the management of this dreaded disease. In summary, therefore, amyloid is ubiquitous. It is a force multiplier for our current diseases that the patient has. Multi-system involvement for any disease is an important factor for suspicion. Coexisting atrial fibrillation definitely needs anticoagulation. There is no CHADS-S2 for these patients. In fact, in our unpublished data right now, in a series of 90 patients above the age of 60 who've been evaluated with a pyrophosphate scan, 30% of them have positive pyrophosphate scans. So again, the risk for stroke, cryptogenic stroke, may be manifold, especially in elderly patients who present with atrial fibrillation. Aortic stenosis with cardiac amyloidosis, undergoing TAVR, there is a definite benefit in mortality reduction in these patients, and TAVR should not be withheld just because amyloid is there. It needs to be ruled out definitely, especially in patients with HFpEF. Syncope in the middle age, neuropathy presenting in middle age, even in the presence of diabetes, needs particular evaluation, and coexisting hematological disease and ATTR can be possible. All it needs an immunochemistry to actually figure out the diagnosis. Thank you for your patient hearing. Happy to take some questions.